Hi, thank you again. I can't beat this beautiful sari that Margaret had. But I did fancy a skirt that I just saw from the south of India for men. So if you see me next time in a skirt, I didn't get crazy. I just believe it's more convenient. It's so funny, you know, in ancient Rome and Greece, actually, only barbarians wear trousers. And nowadays everybody do, so it's terrible. Thank you very much again for inviting me here. I will try my best to represent what's new in the guidelines, and I will also add a little bit of what is important. I'm sorry, those are my conflicts. So the mission also of ISPAE, which I believe is very important, as you will see, and as it was quite obvious from the discussions that we already had today, particularly from regions like Bangladesh. I will start with type 2 diabetes. I will touch a little bit monogenic, and I will leave this topic to the next speaker who is much more proficient in it than myself. I will speak a little bit of type 1, and I won't speak much about technologies. So what's new? What's new in the guidelines is that we, for the first time, publish an estimate of type 1 people in the world, and this is children only, so 0 to 18, and as far as I understand, it's hugely underestimated. So when we say that type 1 diabetes is the most common endocrine disorder in children, we are probably right on target. I would assume that it's at least 500,000 underestimation, particularly from countries like China. There are novel medications that we'll touch. There we will touch genetic screening, NGS in particular. Second generation insulin analogs we will discuss. We will discuss ultra-rapid a little bit. Adjunct therapies are new, and this I will tell you something that will happen in 2 days in India. I'm interested to learn if you know it, related to novel medications for type 2. In technologies, we already discussed pump and sensors and closed loops and advisors, and we discussed the targets in addition to A1C, and I will just show you how the guidelines actually touch these issues. I think the most important is that the ISPAE guidelines should be acceptable worldwide, and it's actually an open peer review system. So when a chapter of the guidelines is written, it goes to the web page, and everybody has a right and a chance to comment and to improve. And when they are done, they are freely available. And what's also important, and I will repeat this twice, is it is a duty of physicians, so of us, to improve awareness among governments, particularly healthcare providers, general public, of the burden of this disease. It's a terrible disease, if you think about it. Basically depends on what you do, on how you behave, and if you misbehave, you pay dearly. So it's quite unfair to all these people, actually, if you look at it this way. It's individual caregivers that must be assisted and taught. And we have to be careful, actually, to provide evidence-based medicine. This was already discussed a little bit by cure of diabetes, which is widely discussed, and as stressed, actually, there is no such thing. Unfortunately, the media, particularly the web, the internet, actually is quite unfair, and physicians have to be ready to discuss this with people. And of course, many regions in the world cannot afford the best care, so there is also a chapter of limited or minimal care that we believe is important. What's actually new in type 2? So the first question that is addressed, and I think it's very important, is the screening. And it's a huge dichotomy in the world. So as screening is really not justified in Europe, it actually is probably justified in many communities in the United States, and there is a beautiful paper on New York, actually, where screening in certain environments in schools may be quite cost-effective. And there are regions, actually, where the screening was proven to be cost-effective, particularly in Japan, where actually children get the diagnosis of type 2 when they already have retinopathy. So it's a very quickly progressive type of disease, and particularly Tatsuiku from Tokyo University published extensively on the importance of screening. The second thing is that they are actually risk factors that should guide us to screening. So if in our, let's say, European environments, we get a child that has several additional risks, then yes, of course, we should screen and test this for diabetes and for other diseases, as we will discuss. We use criteria same as in the adult population from the American Diabetes Association. Usually, it's advisable to repeat the test at least twice. And the reason for this is that in our environment, when we see an obese child is at risk, he gets so much torture on him, actually, that usually loses weight. So that is, diabetes in our environment usually disappears before the diagnosis is given. And at the moment in my country, there is not a single child with type 2 diabetes. The last one was 5 years ago. Because the public programs are so harsh that we see a reduction in mean weight in children in our country, similar to France and Sweden. And this is, of course, published. We still see a higher obesity rate in adolescents, so this is now the new target area for the pediatric services in our Middle European environment. There are less and less typical type 2 diabetes. We always have to think, actually, that it may be a monogenic diabetes behind and work into this direction. Prepubertal children in almost every environment are highly unlikely to be type 2. So other things should be probably, imagined. Antibodies are actually a very good marker. As you can see, I always put the grade of evidence in the bracket. So if it's A, it's very high. It's the highest there is. So antibodies should be a good guidance. If you can do at least GAD, it's fine. If you can do the triplet of them, it's very, very secure. And then, of course, comorbidities should be tested, and this is of utmost importance. They may be children without diabetes, but they do have hypertension because of obesity. At least in our environment, this is the number one complication of obesity. And they may have actually early kidney damage, as described in the Japanese population. They may suffer from obstructive sleep apnea, very often of depression, particularly poor self-image. As mentioned previously, they almost by definition have eating disorders. They may have impaired cognition. It's increasingly common. And other actually psychiatric comorbidities like attention deficit disorders. And of course, in some environments, the possibility of pregnancy should be actually taken into consideration. Initial treatment, we are back to the lifestyle, but this is very rarely efficient. So you need a total society movement actually to be successful, and it takes decades to do it. So if a society movement is so large that you have, in school, in public, in the way the food is advertised, in the way that, food is offered in schools, then you may be successful with a lifestyle intervention. If all this is not in place, you shouldn't be disappointed if lifestyle intervention didn't work. Initial pharmacological treatment is still metformin. The beauty of metformin is that it is really inexpensive. It's really cheap. The problem of metformin is we don't really know how it works. So the mechanism of action is still disputable. You probably read the 3 Lancet papers 2 years ago trying to describe its way of action. We don't know really. If you use it in a very high dose, you get lactic acidosis. It's a trouble if you have a renal problem. So there are several issues. And as you know, in the new type 2 guidelines for the adult population, there is a huge debate whether metformin should still be in the first round of recommendations or it should be omitted from the choices. The goal, same as with type 1, is A1C below 7 at the moment. And of course, self-monitoring, particularly if insulin is used, actually is mandatory. So if you fail to bring this young person with type 2 diabetes below 7 with whatever was actually tried, then you have to start by guidelines the basal insulin. And this used to be the only thing, and I am courageous enough actually to challenge this initially, and we'll discuss why. And other pharmacological agents actually are there, and we will discuss them. Sulfonylurea is out of question because it actually accelerates the beta cell loss. But they are GLP-1 receptor agonists, they are SGLT2 inhibitors, they are DPP-4 inhibitors, that all are likely safe and efficient. And the news that I wanted to share with you is that there will be a generic DPP-4 search in India, and the price of these drugs will drop to 9 rupees per tablet. So it will become at least twice, if not more, cheaper within days, because the patent actually expires. And I understand there will be, I was told, dozens of companies offering DPP-4 generic preparations for the price around 9 rupees a day. So probably another option that is more affordable. Glitazones are a question. They were discussed already a little bit. They have some good things, particularly for NASH, but are otherwise a potentially dangerous drug. So there is a question mark, although they are used in the United States and elsewhere in children. And of course, there are combinations. For GLP-1 receptor agonists, we now have a very recent randomized controlled trial published. And they work beautifully. So here actually you see, this is the glycosylated hemoglobin, and you see a 0.5% drop. This is the fasting plasma glucose, and you see a beautiful significant drop. And this is the weight difference actually after a year. So all three major advantages of this drug that were time and again proven in the adult population are also present in the pediatric population. So quite obviously an indication for children is expected very, very soon. This was liraglutide in this particular study with this beautiful outcome. I don't doubt actually that other preparations will do exactly the same. They are actually comorbidities that you should test. Before this, actually, I'm not sure where the slides are, but there is also a huge benefit of SGLT2, as we will discuss. So urine to creatinine ratio, albumin to creatinine ratio should be assessed at the beginning and then at least annually. And it should be treated either by ACE inhibitors or by angiotensin receptor blockers. Second, if the first is not tolerated well by definition, and they could be non-diabetes related causes of renal disease that should be excluded. And of course, always blood pressure whenever you have a renal trouble should be meticulously maintained within the normal range. Blood pressure per se, as mentioned previously, is the most common complication or additional comorbidity with type 2 diabetes. It should be properly measured and at every single checkup with the physician. And if it's above 95th percentile in pediatrics, and these centiles actually are for height, it correlates with height the best, an ACE inhibitor should be introduced and blood pressure really maintained within the below 90th centile. And again, if ACE inhibitor is not tolerated, which sometimes happened actually, particularly with cough in the younger population, an ARB or a calcium channel blocker can be actually started, or finally a combination therapy if this is required. Dyslipidemia is the next after blood pressure. It's even in this population also before diabetes in our environment, probably after in your environment. It should be tested and it should be treated. So if LDL is above 100, some people even told me above 70 in some very stringent environments, you should start statins. And statins actually are very successful. So after the trial with the diet and with the metabolic control that usually are not successful within 3 months as suggested, you should actually, repeat it and then treat it with statins. Atorvastatin is safe and was proven to be effective in children older than 8 years of age. So Atorva actually is formally approved for children in the European Union, but also more modern preparations work as well. So it's actually a choice what is available and what is most accessible in your environment. Triglycerides are sometimes a problem. And of course, as you know, they increase the risk of pancreatitis, so they should be treated preferably with fibrates at the moment in pediatric population. Retinal examinations are necessary. I told you that in Japan, they published actually that at the diagnosis, a very high amount, above 10%, of children actually already have incipient retinopathy. So it may be that in your region, this is also the case. Non-alcoholic fatty liver disease and NASH is a relatively new entity. It's very common in children also and should be recognized. The guidelines suggest that you use 3 times the upper, not your lab normal, but the upper international normal, which is gender dimorphic, 22 for girls and 26 for boys. And if so, actually, what you have to do first is you have to exclude other causes of hepatitis, particularly infectious or autoimmune, and then you actually try to intervene. There are newer drugs coming, none of them yet approved outside glitazones, but they soon will be, and there will be a separate actually session during ATTD on NASH and on modern therapy on NASH for those that are interested. I really like this little figure, because what we need to do in type 2 now, also in pediatric population, is really choose the most appropriate medication for our young patient. And this is actually affected by genetics considerably in type 2 diabetes and by the environment. And not every choice, not one choice is good for everybody. So there is really a diversity in what you really want to pick as a primary drug. Here, the availability is not mentioned, but obviously also the availability of different drugs play a role. Monogenic diabetes, actually, the recommendations are clear. It's actually uncommon, 1 to 6%. It's obviously there if the diabetes is diagnosed in the first 6 months of life, so this is a special period. Probably if the child is, referred to you later when the signs were already present, it's safer to say for the region the first 12 months a genetic test should be done. If you have the chance to do the antibodies and the workup, that may be different. But generally, it's not wrong if you do a genetic panel up to 12 months. This is, again, I think, clinically useful approach. Why? Because actually the outcome, as you can see, is therapy. So probably those diagnoses that would affect your treatment are the most important. And here, as you can see, you have 2 modes that are responsive to sulfonylureas, and this is, of course, good news. There is mode 2 that doesn't need any therapy, which is the best news, likely. Outside pregnancy, please be careful, because during pregnancy, even mode 2 requires therapy. And there is, let's say, mode 5, actually, that needs insulin. Why? Because it's a beta cell destruction and, or I should say, development defect, and it immediately requires insulin treatment. So a panel actually can guide your therapy early on. You don't have to try different things. You just do what is appropriate for the diagnosis. And here you have, from the guidelines, a table that summarizes by actually the major sign. This is the abnormal pancreas development. As you can see here, you have either transient neonatal or permanent neonatal diabetes, and this will be, I'm sure, better discussed in the next lecture. You have abnormal beta cell function here, and you have the destruction of beta cells here as monogenic causes. And of course, as mentioned previously, it's highly advisable to get a genetic test early and to make a tailored decision, actually, for the specific therapy. Here you also have, on the other hand of the spectrum, severe insulin resistance that also needs specific therapy, or at the end, complex syndromes that include diabetes, among other more serious, particularly neurological deficits that are present. For type 1, actually, what's new is really the emphasis on individualizing targets, particularly on CGM and intermittently scanned CGM, and the most important that now the target also by ISPAE, same as ADA, is below 7 for glycosylated hemoglobin. So it's no more, if the child is little, 8 is fine. It's not. Actually, even children are human beings, and they should have the same target as anybody else. It's a clear A-graded recommendation for the use of CGM and intermittently scanned CGM. And it's stated, as you see, that each child should have access to technology. And again, and this is very important, so diabetes center personnel, so this is us again, should advocate to nations, states, healthcare funders to ensure that children and adolescents with diabetes will have adequate supply. So this is really important, and this is our goal, and we have to be proactive in this important endeavor. Basically, sometimes, the targets, may be up or down, of course, individualized, particularly in very disadvantaged children and environments. You can be satisfied with a higher A1C. And what's also important for some, you can put a more stringent goal, where 6.5 is actually recommended, and many more actually stick to this. Here you have the glycemic targets from NICE, and as you can see here, NICE is the most stringent. This is the ISPAE, the new ISPAE, and this is new because it's below 7 for everybody. And this is the ADA goal that also was changed. So it's not, this is old reference actually, it's now also 7 for children. And if you look at the June 2019 ADA, you will see this was changed. And Lori Lefel did really a great job actually to be able to push this through in the United States. I mentioned novel insulins for type 1, so this is actually the FASP, the faster acting S part. The pediatric study, as you can see, postprandial is obviously better with fasting acting S part. And this is also true for the competitor, for the Urine. It's called Urine. The competitor one, as you can see, postprandial considerably lower when the faster acting, or ultra fast if you want, acting analog is used. And here actually the co-therapy in type 1, particularly with SGLT2, this is an adult study that was actually run by a pediatrician, by our famous friend Thomas. And yes, actually the time in range, if you add this to insulin, is considerably increased, almost 3 hours a day. So a really big advantage for many. Same was shown with DAPA, so this is the DAPA study, where again, despite the fact it's an adult study, a pediatrician here, Moshe Philip, was one of the crucial members. And again, time in range considerably increased by 2.5 hours in this study, and the glucose variability considerably decreased in this study, minus almost 10% altogether. There is a caveat, and this is ketoacidosis in type 1. So be very careful. It's serious. 3 people have died already in Western world. And the ketoacidosis develops without very high blood glucose. So it's really hideous. Those are the guidelines that we put together, published this June. This June in Diabetes Care. The DKA is defined, and it's above 3 millimolar if you measure it in the blood. That really becomes dangerous. And actually, the most important, so we don't go because you probably don't use it now, but the most important thing is that you add insulin and carbs, and then it works well. So you have to add insulin and carbs, and the DKA actually goes away. And you have to discontinue this therapy during illness. So when a person with type 1 using insulin and SGLT2 is sick, it's very prudent to stop this therapy. A special chapter, new one, completely new, is on the school, and the number of young people with more than 30 hours per week in school is almost 100%. So what's important is that they have the same right in the school as healthy children. So we have to make sure that they get what they need by the school personnel. and they can maintain normal glycemia during school. The whole chapter actually emphasizes this, and the schools should make reasonable adjustments to facilitate the prescribed regime. Finally, just actually the recommendations, as you can see, for pumps grade B and for sensors grade A evidence that they should be used. And the targets already here for the first time are time in range, time below range, and time above range, also in the ISPAE guidelines, as discussed previously. Telemedicine actually is discussed, and if I remember the lecture from Bangladesh, actually, huge distances is a problem, and this is many countries in the world when huge distances are a problem, and telemedicine actually can really help, and there are 2 papers now already published on this topic. To conclude, actually, type 2 diabetes is a social disease. There are novel medicines, which are very good news. Precision medicine for monogenic diabetes with an early genetic diagnosis is actually crucial. For type 1, there is abundant evidence published for the use of modern technology, and there are novel glycemic targets that are lower for A1C, and there are targets for time in range. And diabetes in schools is a separate issue, actually. When we fix the environment for the child in the family, we should immediately go and proceed to fix it in schools, which was also stressed today, and it's a difficult task, but then the success is very obvious. These guidelines are freely available at the ISPAE webpage here under guidelines. You just put into your browser ISPAE, and you will get them. And the SWIT initiative that was mentioned, India is very good. Look how many spots already are red, and there are some blue, actually. So I hope, the spots will increase. I invite you to join the SWIT community of the ISPAE to be able to get this benchmark for your center and try to kindly compete with the others. Thank you very much again for your attention.